speaker is Paul Davies, and discussing the reality of developing trauma-informed care for autistic people. So a subject to that is quite an important one to discuss, I think. So over to you, Paul.
Thank you very much indeed, Damian. I am desperately looking for the little bar that comes up for me to share my screen, but I don't appear to have it. Oh no, here we are. There we go. So let's have a look here. Just take that off there. Right. Ends up with all kinds of boxes and things, doesn't it? Just desperately wish Elon Musk had taken over Teams rather than Twitter, but there we go. Apologies everybody for the tech issues that we've had. Teams is not the best platform, but it was the only one available. As Damian said, my name is Paul Davies. I want to firstly just take a little bit of time just to thank Damian and to everybody for PARC for their efforts for over the years. It is for me the best autism conference of the year, and this year so far again has been brilliant. I'm sorry, I'm going to drag this downhill a little bit. It's actually genuinely a bucket list experience for me being ticked off, so forgive my nerves. I'm a little bit nervous. I normally just use images and speak to them. The only problem with that is the time doesn't kind of mean a great deal then for me, so I lose time. So I'm actually going to use a script today. The only issue is that I'm not especially good at reading out loud. It's one of these strange things. I can read and I can speak, but ask me to do the same things at once and it all becomes a little bit strange. But I'm determined to keep within the allocated time. I was diagnosed, late diagnosed about 10 years ago. I'm not an academic. I am an autism trainer, but I also am a visiting lecturer at the Critical Autism Studies courses at Edgehill, the undergrad and the master's degree. And I work full-time in a national autism support charity, and various roles, instructor and trainer and stuff. But today I'm going to be talking about discussing the reality of developing trauma-informed care for autistic people. Quoting Dr. Allison Moore, trauma-informed care, or TIC as I might abbreviate it as we move on, TIC should be a strengths-based, which means it's completely incongruent with the deficit model of autism. So without systemic change to autistic, positive approaches to supporters simply will not work. So yeah, thank you. That was my talk. Any questions? All right, maybe I should fill the other 23 minutes that I've been given. Just a little bit about the term. It's the PARC Critical Autism Studies Conference. Critical Autism Studies was coined in 2010 by Joyce Davidson and Michael Orsini, and it really does underpin my approach to life and my worldview. Whilst the definition of CAS is subject to some debate, the actual Mitzi Waltz definition, and actually there's a hyperlink there on the slides when we share it. If you look that will take you to the what for me is absolutely seminal article by Damian, Richard Woods, Larry Arnold and Steve Graby, redefining critical autism studies, a more inclusive interpretation. It's just a brilliant article, and it does lay out what critical autism studies is, and it really says it comprises three elements, which I think in lay terms, Mitzi's is a little bit more complicated, but mine is rethink the approach, reclaim the discourse. At the end of the day, it's our story to tell, and respect the differences. I've always been struck by this quote from Kirsten Linsmith. It's my belief that our perceptions of autism are so deeply informed by autistic trauma that to so many people, a reduction in symptoms of autism is simply what happens when you reduce distress in an autistic individual. Tony Fadell says, you know, it's easy to solve a problem that everybody sees, but it's hard to solve a problem that almost no one sees. And that's true, you know, that is actually true. But the problem is that autistic people have been highlighting the problems for decades. We just need somebody to listen. You know, we live as neurodivergent people, as autistic people, in a neurotypical world. It's a world that's not designed for us. Yet still the dominant model of autistic support, despite huge pressure, it remains the medical model or the deficit model. I guess you can see my feeling on it right from the start. It's really problematic. This approach often ignores the social reality of the autistic experience and the constructions of disability itself. We aren't just in our heads, we live in the world that we are surrounded by. And research has shown that interventions designed to normalise autistic people and cure-orientated organisations and legislation and research that says may contribute to stigma towards autism. I would say it absolutely does contribute towards stigma towards autism. Robert Skur defines trauma as any negative life event that occurs in a position of relative helplessness. Now I'm going to say that again. Any negative life event that occurs in a position of relative helplessness. And if you think about, you know, where we are as autistic people and how we really aren't valued in many ways, I think that's an incredibly important point to make. You know, within our society, many autistic people experience a range of different types of trauma on a constant and ongoing basis. It's always there, isn't it? It's tick, 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 tick away from a wide range of sources or intersections, whether it's based on deliberate social exclusion, as happens to an awful lot of us, discrimination. You know, autistic people are a very disparate group of people. Bullying, misunderstood or treated poorly. And research has consistently shown that autistic people have a higher risk of adverse childhood experiences within the deficit model. Such events have consistently linked to immediate and lasting health disparities, including PTSD, post-traumatic stress disorder, complex PTSD, anxiety, depression, and other mental health issues. Certainly for me, you know, I have complex PTSD, I've suffered from depression in the past, and other mental health issues. It's really, really challenging sometimes. You know, the unpleasant historical reality of the deficit model is based on this idea, this ethos of a mythical, socially constructed normal. Have you ever met that normal person? Because I haven't, you know, and you think about that, is that, you know, it's effectively a white male heterosexual person. That's the autistic. Autism is white kids, isn't it? That's what we think of. Now think of the rhetorical violence that perpetuates. It's not going to work in this amazingly, wonderfully diverse community of ours. See Remy Yergo, or at the time some of the work was written, they wrote was under Melanie Yergo for more work about rhetorical violence. Think about that, you know, you're disordered. That's a pretty violent thing to say to somebody, you know, and it then effectively just renders my voice unreliable and deficient, which means it can be ignored. You know, there's a quote from Remy Yergo at the time saying, you know, having been diagnosed, I am now no longer the author of my own body. It's an incredibly powerful thing. And indeed, you know, many people might actually dismiss what I'm going to say today because, well, he's an activist. We're experts, we're scientists. No, it's a challenge. You know, the next few slides, I'm going to look at the social and emotional impact of the medical or deficit model on trauma-informed care, because this is what we have to live with. You know, Nick Choan, and no pressure here, because Nick is actually following me on to present, so I've really got to get this right. And Nick, within their work, they found that it's both epistemologically as well as ethically problematic if the autistic voice is not heard in relation to social scientific research seeking to further develop knowledge of autism. You know, otherwise, if we're not, it's just somebody's opinion, and it's a neurotypical's personal opinion of what it is. It isn't ever going to be correct. You know, as Nick goes on to say, ever since autism first emerged, it's remained medicalized and almost exclusively the preserve of non-autistic researchers. You know, and as a result of that, autistic children are often told that what they feel, what they think, what they do is wrong, and what they have to do is what they're told. You know, we're trying to make them neurotypical. Newsflash, they never will be. They are autistic children. But forcing that change can have a lifelong impact on self-esteem, self-confidence, and self-advocacy. As a result, trauma of victimization inevitably leads to the development of masking within relationships. And as a slight aside, I should probably apologize. I have a load of dogs, a ridiculous amount of dogs living in the house, and you might hear them barking in the background, so I'll apologize for that. It wasn't me, and it was actually the dogs. In their excellent paper from last year, Amy Pearson and Kieran Rose observed that autistic masking is the conscious or unconscious suppression of natural responses and the adoption of alternatives across a range of domains, including social interaction, social experience, cognition, movement, and behavior. You know, we learn to fake it, don't we? You know, and it does us no favors. It's incredibly hard, and it's incredibly damaging to us. But we have to do it. An awful lot of us feel we have to do it. You know, so what that leads to is not only do we experience higher rates of various forms of abuse, but we also experience more barriers to accessing subsequent support, such as health, social care, and domestic abuse services. You know, well, you look fine to me. Yeah, I'm masking. The term iatrogenic harm, I think, is one that we really need to look at more closely. And this isn't me having a go at doctors or whatever. I understand you work within a system, psychiatrists, psychologists, you work within a system that you work within. But iatrogenic harm is from the Greek, brought forth by the healer, and it refers to any effect on a person from the actions of a healthcare professional that negatively impact their patients, including physicians, surgeons, psychiatrists, psychologists, and therapists, and many more. You know, I genuinely think that professionals continue to underestimate the number of and the lived experiences of autistic patients under their care. You know, there's an awful lot of undiagnosed autistic people seeking support because they're undiagnosed, and two, there's an awful lot of comorbid mental health conditions that sit alongside autism. You know, and if you don't understand, if the professionals don't understand these people or accept the reality of our cognitive differences, and that's, you know, quite often due to poor training and lack of contemporary information, it's really problematic. One size has never fitted all, clothing or anything, whatever, but especially in a community with so many intersections and gender or cultural differences. You know, I found this statistic incredibly depressing, in all honesty. Within the deficit model, suicide is the second largest cause of death for autistic people, with suicidal thoughts reported in 66% of newly diagnosed people. And that was with Asperger's. So clearly it's a slightly older piece of research, but it's still a valid piece of research, whilst the label might be slightly different. They were still the same people, we're just called something slightly different now. And up to 30% reporting suicidal behaviours. You know, within the medical model, autistic people, adults, have poor physical and mental health compared to the general population. We experience premature mortality, and life expectancy is potentially reduced by 16 to 30 years. And Sydney is a 60-year-old man who is 2 years older than the average age of death for autistic people. That's really quite scary. And also with increased mortality across all diagnostic criteria and categories. You know, within the medical model, autistic people are over twice as likely to use A&E departments. and also to die after attending emergency care, and 3 times as likely to require inpatient admission, where in hospital mortality is higher than non-autistic people. And yet we persist with the system, which, you know, increases the potential to kill us. It's incredibly scary. You know, as Robert Chapman and Monique both recently observed, you know, clinicians should develop a healthy skepticism to pathology paradigm researches, which routinely assumes and reproduces negative biases about neurodivergent people. How many times do we open up an article and see that first paragraph that says autism is a deficit model? And it's so depressing. And it doesn't need to be. And the problem with that is that stigma is interwoven with all of the approaches that other or dehumanize people when compared to a socially constructed normal person. Again, I don't know who this person is, but I've never met them. The deficit model creates stigma and discrimination. You know, Monique both are, again, I think I love their work. Their work is amazing. And the work of David Frost demonstrated a clear relationship between minority stress and mental health in the autistic population, and the huge importance that community and acceptance can play as a buffer to stigma and stress. It's why whenever anybody asks, I say, yes, I am autistic. No, I'm not a person with autism. I am autistic, and I'm proud of that. Being able to say that and knowing that I have a community around me is incredibly important. But we are really victimized as a community. Amy Pearson, Kieran Rose and John Rees study this year looked at autistic adults' experiences of interpersonal violence and victimization, IPV, within personal relationships. And they found that one factor explaining the high prevalence of IPV is stigma. Again, stigma. You know, autistic people are stigmatized at a group level because of negative perceptions. And again, some of the stuff that we've spoken about earlier, right? You know, we can't even play correctly, or the pictures that we see on the news. Like, I'm not Sheldon Cooper. I hate Sheldon Cooper, can I just say? You know, and those perceptions that are built by the media, and also at an individual level for failing to meet normal expectations. You know, they also found that victimization was viewed as a normal part of life and had come to be expected. I thought that was absolutely horrifying when I read that. I got my highlighter pen and wrote that and made all kinds of exclamation marks. You know, that when victimization is viewed as a normal part of life and it comes to be expected, the system that we now live in clearly needs to change. You know, Roy Richard Brinker said, stigma it's not in our biology, it's in our culture. It's a process we learn from within our communities. And we can change what we teach. We can change the ontology. We can change the epistemology. So what actually is trauma-informed care for autistic people? Well, as Damian Milton said, what one considers autism to be will have a significant impact on how one then interprets what is meant by best practice with autistic people. And that's so true. You know? But I think what people don't realize, and what people have to get their head around, is that trauma-informed care is 2 processes. It's based on 2 processes. There's one, the process of becoming trauma-informed, and then there is 2, without the gap in between is and 2. Sorry, I missed that. That'll drive me potty. The process of trauma-informed practice. Now, I would say that we're currently still at level 1. We are still at the first part of that. We need to become trauma-informed before we can even start talking about practice. No, services must realise the impact of trauma, recognise the signs and symptoms of trauma, and respond by fully integrating knowledge about trauma into policies, procedures, and practices. And practices that seek to actively resist re-traumatisation. I've got to say, you know, if that's, you're not setting your goal pretty high, are you, really, if you've got to resist re-traumatisation? But we do, because that's what happens. That's often happens within the way that people are treated when they go to ask for support. It doesn't work as a manager and a group of managers saying, now we are going to do this now. It simply will not work. It's got to be a system-wide approach. It's got to be strengths-based, and it has to be embedded in policy and practice. That yes, it starts at the top, but it only starts from people believing that and changing the way that they look at the people they support. Yeah, simply rebranding the existing deficit-based service, where the focus has always been on individual lack, and now, yeah, hey, now we're trauma-informed. It's not good enough. We have to recognise the social determinants of trauma: poverty, social isolation, discrimination, exclusion. Many of the things that through all our different intersections that we face on a daily basis. Trauma-informed care and the importance of cultural competence in establishing a support environment is vital. So without proper education or training or values, services will often cause more damage if not backed by true organisational cultural change. Currently, nurses, teachers, mental health nurses, they don't have input into autism or neurodivergence in their core training. So at the end of the day, you can't criticise for somebody not knowing what they don't know. But at the end of the day, we really need to move that forward. And the only way forward with that is truly collaborative training. We have to be involved in the training and actually sort of come hear our stories before you start applying staid old theories to us. What do I mean by cultural competence? So I think that's an important thing to clarify, you know, because for some, being autistic or neurodivergent is an identity in itself. It is for me, and with it comes a unique culture. And I think not everybody agrees, but I genuinely believe we are starting to see an autistic culture. You know, we're seeing it through literature, we're seeing it through academia, we're seeing it through media. We are starting to see a growth, and especially online. There is a growing, what I believe to be an autistic culture, and it intersects with all kinds of different aspects of their being. You know, I can sit and talk as a 60-year-old white beardy bloke about my existence and about my way and my culture, but I cannot talk about a 22-year-old Bangladeshi woman. I wouldn't dream of doing that, and neither should you. If in doubt, ask the person how you can help them, and don't assume that you know. You know, 95% of autistic people have hypo or hypersensitive sensitivities to environmental stimulus, often more than one, myself included. Great improvements can be made by addressing just practical things like, you know, look at the space that you're in, change the lighting, think about the noise coming in from different places, think about smells coming in, clutter, reducing challenges by reducing arousal is key to good support. You know, we've got to look beyond this current, so limited focus about autism, you know, about behaviour. You know, ABA, PBS, I'm sorry, they're gone. They, for me, no longer serve their purpose. We are more than our behaviour. And you know what? Behaviours of concern are usually evidence of an unmet need. You know, that's the responsibility of the supporter or the person around it, you know, double empathy. Support must respect and accept natural autistic behaviours, stimming, you know. Quiet hands are not happy hands for children. So if there are any teachers there and you've said that, I'm sorry, stop saying that. Stop doing that. Stop thinking about that. Because all you will do is, by suppressing the autistic natural act of self-stimulation and its soothing results, you're going to lead to distress. So by doing that, that increases the feelings of anxiety and distress within the environment. I have a bit of trouble with this diagram, I'll be perfectly honest with you. It's a diagram of therapeutic needs hierarchy created by clinical psychologist Kim Golding, Australian, 2015. It's clearly based on Maslow, and it's commonly used to describe the stages required to work with trauma. I'll describe this just in case you haven't actually got, you can't see the pyramid, but it's divided, it's a pyramid divided into stages working from the base upwards. And the first thing that they say is required is feeling safe emotionally and physically. Then above that is developing relationships, comfort and co-regulation, and then empathy and reflection. I'm sitting there, well, if you haven't got that before you actually, nobody's going to feel safe. Then resilience and resources. I cannot stand the word resilience. I absolutely despise it, because it's usually what they mean by resilience is, well, you know, can't you just work a bit harder? Can't you just keep on pushing through? That's what resilience means to me, and that's the way that it's used within support services on a regular basis. And it really, really isn't good. You know, it's steeped in developmental psychology, where poor parenting is often blamed for infant traumatization. In fact, Golden says, children traumatized within their biological families are described as children who have experienced complex trauma. Well, yes, that's potential for some people, but however supportive of parents are, you know, if a child is going to be labeled disordered by experts and is constantly in a state of high arousal because of chaos around them, how are we ever going to work with that? We're not, and that's not the parents' fault. Parents can be absolutely brilliant and doing whatever they can possibly do. You know, how do we even achieve the most basic state of feeling safe emotionally and physically if the lived, or indeed the support environment that you're asking that person to go into is hostile and constantly hostile? You know, can we ever feel safe in a therapeutic system that in practice often perpetuates stigma and discrimination? Well, Robert Chapman and Monique Botha, very recent paper, suggests that there are three key themes of neurodivergence informed therapy. I love this paper. I thought it was brilliant, and it's really timely. First, we need to reconceptualize the idea of dysfunction as it's relational rather than individual. You know, anybody, we should really all know that we all are part of an interconnected society. You know, this is the problem, when there just hasn't been enough sociology in autism. We really need to be looking at the world that we live in. It's not our fault as an individual. Secondly, the importance of neurodivergence acceptance and pride, and disability community and culture to emancipate neurodivergent people from neuronormativity. I realized a while ago that I'm pretty rubbish at being a neurotypical. Despite trying for decades, I failed as a neurotypical, quite spectacularly in some cases. But I'm really good at being autistic me, and having pride in that, and accepting who I am as a person and who I am, and being part of a wider community, a disabled community. Yes, autism is disabling, but it doesn't mean that means I can't be proud of who I am or what that is. And if a therapist doesn't understand that and wants to tell me that as an autistic person that is broken, then that's really problematic. Thirdly, the need for therapists to cultivate a relational epistemic humility regarding different experiences of neurodivergence and disablement. I've got to be honest, I think that's going to be tricky for some, but I think it's really important. You don't know everything. For me, I'm going to assert that emphasizes the need for the paradigm shift towards critical autism studies, and the neurodiversity movement's approach to how we view disability itself, how we train or teach our children, you know, how we train and educate people as professionals. If we continue to adopt a broken system, it's not going to work, is it? So we have to adopt a contemporary and inclusive ontology and epistemology of disability. Fergus Murray says, and I love this quote from Fergus's blog, which you really should have a look at. People want to understand themselves and those they care about or work with, and that's obviously very difficult. Well, somebody just doesn't experience the world the way you do. What people learn is heavily informed by some dominant theories or media, or as we said, however hazily understood and filtered through the media specialists and others. Sometimes these theories help, but often they don't. I'm not sure they help at all currently, with certainly the ones that we have still coming into prominence. I think we need to develop an organizational asymmetrical reciprocity. That sounds so much easier when I type that. We need to redress the power imbalances. You know, practitioners need to develop a broader understanding of what constitutes a traumatic event to autistic people. Recognize the individuals may have had really previous negative experiences of disclosing trauma in professional settings and have to work differently to create a trusting therapeutic relationship. Sorry, you've got to work at it.
Oh,
yeah.
Sorry for interrupting, but we're running a bit over time. So
yeah. Okay. I appreciate it sounds a bit bleak. So critical CAS informed peer support. This is the final slide. Majority of academics cited in this presentation are autistic and neurodivergent. Did that on purpose. The expertise is already there within academia. You just need to listen. You know, recruit more people into the sector. They bring with them their knowledge and experience. You know, it's not going to happen without a fundamental shift in the approaches to autism. You can't just say you offer a new approach while maintaining the primacy of the failed medical model. True trauma-informed care must be autism positive and treat us as human beings for it to work. You know, so I guess the final question begs to be asked, you know, is it neurodivergence acceptance, trauma-informed practice that we need, or is it actually just good practice?